I'm thrilled to present our next speaker, Dr. Jordan Shlain from America, from private medical, a GP, and he will talk about the challenges of a GP facing longevity medicine.
Thank you, Evelyn. Is this working? Yeah. Can we hear me? Thank you, everybody. I've been practicing medicine for 25 years in the United States. Oh, did I hit this right here slideshow? Excellent. Started on a little scooter making house calls back in the late 90s. And now I run a series of 6 clinics across the United States and have really tried to think slightly differently about how we take care of people and how we think about medicine. So I want to start with hold that thought. Well, no, not that. This is the Campanile at UC Berkeley, where I studied physiology in California, and I double majored in physiology and philosophy. And in physiology, when you're pre-med, you get a lot of tests that you have to take, and for every test you take, there's right answers and wrong answers, and if you don't get the right answer, you don't get to take the next test, and you may not make it to medical school. So for every question, there's one right answer and 1,000 wrong answers, and you must always get the answer right. So meanwhile, I was studying philosophy at the same time, and when you're studying philosophy, you don't really care about the answer. You really care about the question. And all you think about is getting the question right. And are you asking the right questions? So, thought experiment. If you got the right answer to the wrong question, you're right, but you're wrong, and you didn't even know it. So it's really important, I think, as we enter the space of longevity, that we really spend the time asking the right questions. So you'll find me doing a lot of that. So here we are in 2023 at this conference in Copenhagen. We take care of thousands of people, all very interested in innovation. I started in Silicon Valley in San Francisco, so we take care of all the techies. They all want the latest and the greatest. And yet here we are with 1,000 new things we're learning here today, and we have a lot of questions about what's real, what's not, on the one hand, and then there's all these papers being written, and we're trying to filter out, like, what's real, what's not, what questions should we be asking? How should we be thinking about taking care of people holistically? So this is the Fountain of Youth, Ponce de Leon. You guys probably seen this picture many times, but everyone's been searching for this Fountain of Youth, and as many people today have been presenting, trying to discover what are the ways that we can keep living longer or even reversing aging. And while this is really interesting, I live here sometimes on the Mountain of Truth, and I have to put people, over the course of their lives, and over 25 years, I help people, die with dignity, hopefully in their home, with their family around them, and it's a real thing. And so as much as we want to focus on how you live longer, we do have to bring the two things together of this fountain of use and this mountain of truth as a philosophy of empathy. So the critical questions that I ask about this space and where we are is longevity living longer than your natural expiration date, or is it making it to your natural expiration date? And we've seen there's lots of pathology that can cut you short of making it to your naturally programmed expiration date. But ultimately, at the bare minimum, do we all want to make it to our naturally programmed expiration date as healthy as possible? We'll call that health span yes. So that's part one, but then humans are messy. Every single person has different ideas and goals when they walk into the doctor's office or when they just think about their future selves. So how do we honor individual goals? We always talk about populations. I like to joke that there's no evidence for evidence-based medicine when you're dealing with an individual, because that individual lives on a Gaussian distribution, and evidence is just a guideline to help you think about how to think about that problem, but you have to use other tools to find out which one they are. And then the other one is risk. I was at a bar last night with some folks that were doing lots of things to their bodies that I would say were risky, but they wanted to take that risk. And I have patients that want to do that, and I go along for the ride and co-pilot that journey, but I try to test and measure lots of things along the way to make sure that they're not harming themselves. So I wanted to briefly talk about the ontology of prevention, and the other speaker talked a little bit about prevention. Does everybody know the 5 types of prevention that there are? Raise your hand if you know all 5. Okay, so the first one is primordial prevention, and primordial prevention is to make sure that your kids make it to childbearing age so the species doesn't become extinct. So that's just parenting, but that's primordial prevention. We don't really think about it as a species, but we all do it when we have kids. Primary prevention is, the other speaker mentioned it, methods to prevent and avoid occurrence of disease. This is seatbelts, this is vaccines. These are these things that we all know work. Secondary prevention, I won't read it, but it's methods to detect these things. So if you have high cholesterol, no symptoms, high cholesterol, and it's genetic and you can't exercise your way out of it, you take a statin. So that's secondary prevention. So now let's say you had the heart attack, you had symptoms. Tertiary prevention is now putting in a stent and maybe putting you on Repatha and doing more aggressive stuff so you don't have another heart attack. That's tertiary. So quaternary prevention is the newest one. It was coined in 2018. And it's methods to mitigate or avoid results of unnecessary or excessive interventions by the healthcare system. Yeah, so the healthcare system is now doing harm. And part of it is because, at least in the United States, there's a lot of transactional, the sicker you get, the more money they make. I live in a world where people pay me a membership fee, and I tell them, your good outcome is my good income. Your bad outcome is my bad income. So I sit on the same side of the ledger as all of our members. And I don't call them patients, I call them members. They're only patients when they're sick. So you guys have probably seen this. This is how long the life of an average person is, 4,000 weeks. It's kind of jarring to think about how many weeks have gone by in your life, and this is, again, this is average. Everybody in this room is clearly above average. So as just a framework to think about a lifetime. So if this was me and I had 4,000 weeks, this is my expiration date, according to the average. Now, I'm 56. I don't really want to, I want to go past that. I think hopefully all you want me to go past that too. So I want to make it to 2067. I'd like to make it to 100. I'd like to make it to 5,000 weeks, basically, or 5,200 weeks. So the question is, how do I know which one of these I am? And how do you know which one of these you are? And I'll tell you right now that unless you're measuring things over time and using the same parameters, you don't. But I bet if I asked everybody here, which one would you like to be? I know which one you all want to be. The truth is after the age of 24, when the epiphyseal plate of your pinky closes and you stop growing, you effectively start aging, and you are a depreciating asset, if you think about it from an asset standpoint. So the goal is to start to understand which trajectory you're on and try to get you up to the top one so that you live a long and healthy, this is health span, a long and healthy life. And the part 2 of this, I didn't make the slide, but the other thing is if you fall into a medical ditch for some reason, and whether it's a heart attack or a car accident, whether it's something that could have been avoided or something that couldn't have been avoided, the longer you stay in that ditch, when you come out of that ditch, you've lost some of your trajectory. So you've got to get out of the ditch as fast as possible. And that requires like a medical system that enables that and an advocate to help you get out of it. So I want to do a brief, so Silicon Valley, I have an office in New York, an office in Miami, an office in LA. You can imagine the kind of the folks that we tend to. And my father was a surgeon. I grew up, with son, you can be whatever you want when you grow up as long as you're a doctor. And so in the olden days, we lived in the sick care model, which is the patient would see the doctor when there was a problem. That was the way it always was. There was no doctor checking in with patients. There was no proactive. It was all reactive. And then the internet turned on, and we have this thing where we have the informed patient. They can go online. I remember when Yahoo turned on in the 90s, patients would come in with huge pages of paper. What do you think about this, doctor? I think I have this. This is like long before ChatGPT and all that stuff. So then what happened, and what's happening right now, and this is kind of the main challenge for me, is the rise of media influencers and capitalism in medicine. And so now patients go on social media, they go online, they find something, and then there's a guy or a girl with a podcast and a website, and they've never seen a patient in their life. They don't know anything other than what they read in a paper. And then they wind up, so I have people coming to my office all the time, hey, should I take high-dose metformin and rapamycin, and so what happens is that combined with this, and I know somebody else put a slide similar to this, there's all this hype in longevity and anti-aging and aging reversal, and everyone's like super excited. Oh my God, is this the next big thing? Which I hope it is, but as we know, in Silicon Valley, they say move fast and break things. In medicine, we say move slow and don't kill people. So there's just a slightly different approach because things take longer. And so this is kind of the stuff that I get asked all the time. Should I do it? How much should I do it? I mean, and this goes from like rapamycin, and rapalogs are legit. Like there's legitimate science behind that, not in large scale human studies. To full body scans, to ozone, to hyperbaric oxygen. But I just got asked, hey doc, what do you think about rectal ozone? Should I do that? Will it make me live longer? I said, what? They said, yeah. I said, I don't even know where to start. I'm not even going to answer that question. So there is a lot of like crazy town stuff out there that like I see because I'm on the front lines of kind of consumers. So this is a guy, friend of mine, called me up and said, hey doc, I need your help. I need a neurosurgeon. Why? I have a brain tumor. Oh my God, that's terrible. He's 47, 3 kids. And there's his brain tumor. And I said, well, what kind of brain tumor is it? He said, it's a meningioma. I said, well, okay, well, that's good. It's not a killer one. Those can be treated. And I said, who's your doctor? And he said, well, I've been seeing this longevity doctor, who will not be named. And I said, oh, well, send me the medicines that you're taking. I want to see what they have you on. This is the program. So it's hard to see here, but these are the morning supplements. These are the pre-workout ones. These are the PM ones and the bedtime ones. And 3 of them are hormones. Arimidex, HCG, testosterone. It turns out that he has a hormone-sensitive meningioma that probably would not have grown big and fast and compressed his optic nerve like it is now. So here you have somebody, and he didn't really have any symptoms when he saw this doctor. He just wanted to optimize. And so there are risks. There are inherent risks in doing things if you're not really understanding who you are to begin with. So this is my framework for my philosophy here is safety and efficacy. That's it. The two dimensions. Is it safe? Is it effective? Do you want to take risk? Do you not want to take risk? And so if it's safe and effective, it's probably FDA approved. You're probably, no harm, no foul. Probably is going to work. If it's safe and not effective, like a lot of vitamins, because they've never been studied, but Linus Pauling and got old and said vitamin C was the thing, and everyone takes vitamin C. But all you're losing is your money. So you're out of pocket some cash. Oh well. Now, if you do something that's effective and not safe, which there's a lot of people taking super high dose testosterone, these guys, and it's effective. They feel it, but then their blood pressure goes up, their cholesterol goes up, like all sorts of other things in their body start going haywire if they're not paying close attention. And so that's gambling with your health. So I would say, if you gamble with your health because you believe that you have an anti-aging solution on your hand and you're wrong, you can't get that back. You probably can't get that back. So be thoughtful when you put things in your body, on your body, around your body, that don't have a lot of validated safety and efficacy data. So that's just the truth. And obviously, if it's not safe and not effective, like you're an idiot, don't do it. Why would you do that? So on the subject of prevention, and I lean deep into newest technologies, and there's been a lot mentioned earlier today. This is a proteomic test that, right now, if I had to guess your risk of a heart attack, I would use the ASCVD risk score. I would use these old databases. I'd run it against a population cohort. I would not compare you to you. So this measures 9 proteins out of 7,000. I think there's 14,000 canonical proteins in the body, 20 years of back testing through biobanks, and this will give you a pretty accurate risk score of your risk for heart attack, not like you against the population, it's you against you. This is the protein exhaust of your coronary arteries. So I have a guy who's 62, just sold his company, was doing really well, and I said, you 6% score. Like, remember that blood pressure I told you to get under control? You won't take the medicine all the time. Like they were saying, if you don't feel it, why would you take it? And I said that your wife complains of the snoring because we take care of entire families. I said, you got to lose the weight. So, and I said, you just got to lose the weight, lower blood pressure, and this score will go down. You have all these risk factors, and they're being manifested in a proteomic risk score. So I gave him some Mounjaro, because I just didn't think he could do it on his own. Here's the GLP, go. I bumped into him at an event, I don't know, 4 or 5 months later. He had lost 25 pounds. He looked totally different. I'm like, that Mounjaro works like a charm, doesn't it? He said, doctor, I decided I was going to do it on my own. I did not want to take that Mounjaro. So he donated the Mounjaro to somebody else. But his score 6 months later showed that he decreased his risk by half. That's a big deal for a 62-year-old guy. So, and that's just this, and these tests are coming out all over the place. And so when you start measuring the person against themselves over time, you get these trend analysis. You can go back to the chart, which one are you? I had a 38-year-old guy who said, I want to have a family doc. This is kind of a famous rapper. And he went public with this because, and I used this, he said, but my grandmother and my mother had some type of cancer, but I don't know because the black and brown community, not a lot of good records there. And I said, well, it's funny, there's this new cancer test that just came out, cell-free DNA. So we did it, and it came back positive for colon and rectal cancer. I'm like, okay, I got the first false positive test. We did a colonoscopy. Well, we did the garden test, and it was positive also on the poop test. And then we did the colonoscopy, and there's a 2-centimeter tumor in his colon, transverse colon, and it was stage 2B. Took it out, chemo, radiation. His wife is now like 8 months pregnant. He's about to have his kid. He's 2 years cancer-free. Okay. So he would not have gotten his colonoscopy till age 40. That's the guideline. He would be dead by then, or he would have metastatic colon cancer, most likely. So there are these preventative things that we can do, that we should do, that you should do, but you have to be bespoke about it. You know, I tell people I'm 70% to the mental health lectures earlier. I'm 70% doctor. I'm 15% psychologist, I'm 10% rabbi, I'm 4% bartender, and I'm 1% friend. That's what you get when you get our practice, because I say bartender because you got to tell the bartender the truth. And so like a lot of people sometimes don't want to tell you honestly what they're really doing, but because we take care of families, the wife will tell me, the kids will tell me, I'll hear about it. You can't escape. So, what do I do? This is the stuff that I do. This is what on myself, my baseline testing. People say, should you get a full body scan? And I'm like plus or minus on that. I think that the future of testing is blood, breath, urine, wearables, saliva, and AI. You're going to use the scans to go find the thing that the biomarkers told you. And there's a lot of really cool wearables out there. So I will leave you with 2 quotes. One from our famous Danish scientists, which goes back to language, because I study language and philosophy, is that we are trapped by language to such a degree that every attempt to formulate the right insight is a play on words. And Voltaire, who said that the art of medicine is to keep your patient in a good mood while nature takes its course. Thank you.
Stay.
Oh, good questions?
Yeah, thank you so much, Jordan.
Sure. Is there any questions, or?
Yeah, let's have a question. Yes, we have a question. Loud.
Thank you very much. You said that you studied philosophy, so my question is related to inequality of health, which is a major issue that we are facing, or they are practicing in Denmark. We are facing also in Denmark, despite the fact that it's a national healthcare system. And what we hear from the United States is historically kind of concerning. I practice also medicine in the United States and am aware of the extreme inequality of health. So how do you manage the primary care physician?
Question about the economy of health in America specifically.
Yeah, so full disclosure, I take care of a population of people that can afford a different level of care. During my journey in 2007, I thought about that question a lot, and I thought, wow, there's no technology. Like, I remember I was on an airplane and I was about to take off, and they said, turn your phone off in 2 minutes. And I thought, I could in 2 minutes. I could buy a house, I could buy a stock, I could text my wife. I could do so much on my phone in 2 minutes before I took off, but I couldn't access my medical record. I couldn't communicate with the patient. Like, the system is so hyper-regulated that I couldn't do anything. So I thought, I'm gonna build some software, not knowing what I was getting myself into. So I built one of the very first digital health AI companies in 2008 called Health Loop. And Health Loop was every time a patient came into my office, and then I sold it. Now it's being used by millions, tens of millions of people in the United States. When you leave the doctor's office, you get a text. Hey, just want to check in on you today. How are things going with the problem that you had? So we set up a library of problems, trajectories of recovery, going back to when you leave a mental hospital, you don't hear from anybody for 6 days. We had an 86% engagement rate with that tool. We raised a bunch of money. And so now I feel like, what did I do? By taking, when Mercedes-Benz invented the airbag, the only way to get a car with an airbag was you had to spend a lot of money on a Mercedes. Now they're in every car because it was such a valuable tool. So I use my clinic as a R&D lab of how can I do things to spread them out greater and broader and more democratically. I mean, that's my personal contribution. I think that broadly, I think technology will help a lot, but we have a long way to go to cut through a lot of administrative red tape.
Indeed. Thanks so much, Jordan, once again for being
You're
here.
welcome. Thank you
very much.